Limited, myself, Rohit Nayyar, and on behalf of Lupin, I welcome everyone to attend International Heart Symposia, focus on Emperor Preserve trial. As we all know, heart failure is emerging as a major health problem in India, with a reported mortality of nearly 60% at 5 years, which is higher than many common cancers. Specifically, heart failure with preserved ejection fraction is a global public health crisis responsible for a high burden of mortality and morbidity and becoming the dominant form of heart failure in aging populations. Till now, there has been no proven therapy for HFpEF patients. We have now officially proven therapy for HFpEF patients in India, empagliflozin with proven benefits in both primary as well as secondary endpoints. To discuss in detail, I welcome our today's speaker. Our today's speaker is co-lead investigator and speaker, Professor Javed Butler. Welcome, sir. Professor Javed Butler is also professor and chairman of the Department of Medicine, University of Mississippi. He is also a former director for heart failure research at Emory University, USA, and director of the heart and heart-lung transplant programs at Vanderbilt University. He is also the editorial board on JSEC, Circulation, EJHF, and several peer-reviewed cardiovascular journals. And Dr. Javed Butler has also authored more than 450 peer-reviewed publications. Now, to take the Indian arm of Emperor Preserve and moderator, we have Dr. Yogesh Kumar Kudhari. He is the Director, Arrhythmia and Heart Failure Program, Global Group of Hospitals, Karnataka. Dr. Yogesh is a senior consultant intervention cardiologist and electrophysiologist. He is also a professor and HOD of Bhagwan Mahavir Jain Hospital, Bangalore. Welcome, sir.
Thank you.
Also, the two panelists today, which we have with us Dr. Sanjay Mittal, a renowned director, clinical and preventive cardiology, Medanta Hospital, Gurgaon. And also we have a very senior intervention cardiologist, Dr. Mrityunjay Behera, who is also an ex-HOD, SB Medical College, Cuttack. Welcome, sir.
Thank you.
Now with this, I will request Dr. Yogesh Kudhari to just set the context for today's session. Over to you, sir.
Thank you, Rohit ji, and thanks a lot, Dr. David Butler. He has got a busy schedule, but I think he has taken a lot of time for us, for the Indian audience, and he's at present having a program at the ACC, but still he somehow squeezed time for us. So we are very thankful to him, and I'm sure that we'll get a lot of insights on heart failure with preserved ejection fraction today, and we'll be wiser in treating our patients than we were before. Heart failure with preserved ejection fraction, I will not take much time because Dr. Butler will be discussing in detail, is a growing problem. And even with India, with our growing life expectancy, with the multiple risk factors that we have, uncontrolled diabetes, uncontrolled hypertension, undertreated hypertension, this problem is only increasing. And a lot of obesity is increasing, sleep apnea. So a lot of the risk factors for heart failure with preserved ejection fraction is prevalent in our country, and heart failure with preserved ejection fraction as such is under-recognized by our physicians and primary care givers. So I think a new therapy and an insight into the diagnosis will take us a long way. Without much ado, I will not come between the Dr. David Butler and the today's August audience. I would hand over the spotlight to Dr. Dave Butler, and we will take further discussion and questions at the end of the program. Thank you, sir. Please welcome, sir.
Thank you very much. I very much appreciate the opportunity to be talking to you all, and my sincere apologies that you had to shift the program 15 minutes earlier because of this other presentation I need to give downstairs in the sessions as well. So my job is to give a little bit of a context of empagliflozin as a heart failure drug, starting with diabetes and how and why are we doing trials with a diabetes drug in patients with heart failure. How did it become a drug for heart failure regardless of diabetes? How did that history evolve? And where we land today, and what can we expect in the future? My disclosures are at the bottom, the biggest one being that I'm a consultant to Boehringer Ingelheim, and I was the co-PI for the Emperor Reduced and Preserved trials. So all of this started in 2008 when the US FDA required that all new diabetes therapies should not only be tested for glycemic control, but should be tested for their cardiovascular outcomes. That led to several large trials, and the first trial with SGLT2 inhibitor that came out was the Empiric outcomes trial. It is really worth taking a pause that for a disease that affects millions and millions and millions of patients all over the world, there is no part of the world where diabetes is not common and growing. And for a disease where cardiovascular disease is the #1 cause of death, up until this paper came out 2015, there was no evidence that anything, including glycemic control, reduces cardiovascular mortality. In this particular trial, not only there was a substantial reduction in the risk of cardiovascular mortality, 32% relative risk reduction, as you can see in this slide, there was a substantial reduction in the risk of heart failure, about a 35% relative risk reduction. So that led to a lot of questions that people had in their mind, the biggest question being, what is the mechanism of action? Because we know prior to this study and in this very study, that glycemic control did not modulate the benefit for heart failure. In other words, regardless of your starting hemoglobin A1C, ending hemoglobin A1C, changes in hemoglobin A1C, none of that correlated with the heart failure benefit. So it's something beyond glycemic control. So that led to a lot of pharmacodynamic, pharmacokinetic mechanism of action studies over the past 4 or 5 years. And the mechanism of action of SGLT2 inhibitors, it's really an hour stock in itself. I will suffice it to say that everything that is associated with development and progression of both heart failure with reduced and heart failure with preserved ejection fraction, to some degree or another, the SGLT2 inhibitor have beneficial effects. So if you look at the cardiac structure and function, reverse remodeling, diastology, fibrosis, atrial remodeling, if you look at the vascular function, vascular stiffness, endothelial function, renal function preservation, and renal function preservation obviously is not only important for sodium and fluid regulation, but is also important to be able to enable other heart failure medications. And then there are the systemic effects of SGLT2 inhibitor, decrease adiposity. Visceral adiposity leads to decrease in oxidative stress and inflammation, decreased secondary activation of the renin-angiotensin system and the sympathetic nervous system, and then more organ-related adiposity, so local effects of epicardial fat on the heart and perinephric fat on the kidney. Then there are some of these other effects like fatty acid oxidation and ketone bodies lead to better mitochondrial efficiency and ATP generation, autophagy. So one can go on and on about the beneficial effect. The question is actually now not how SGLT2 inhibitors may improve heart failure outcomes. And we will never find a single reason. It's a composite of all of these things working together that improve the cardiovascular outcome. The question is actually quite the opposite. And the question is, what does any of this have to do with diabetes? Sure, these are good diabetes drugs, and sure, they should be given to diabetes patients with for glycemic control. But if a drug can do all of these things, what we basically have are cardiovascular risk-modifying agents, and they should be tested in cardiovascular diseases, irrespective of the presence or absence of diabetes. So now there are trials going on in patients with heart failure with reduced ejection fraction, preserved ejection fraction, acute heart failure, chronic kidney disease, post-myocardial infarction, and all of these trials, we're using these drugs as cardiovascular risk-modifying agents and not necessarily as anti-diabetic agents. So these trials are including patients completely agnostic of the presence or absence of diabetes. So the first trial that came out with empagliflozin and heart failure, was Emperor Reduced trial. So the Emperor program took all heart failure patients, and basically anybody who had ejection fraction of 40% or less was enrolled in Emperor Reduced, and anybody who had ejection fraction of greater than 40% was enrolled in Emperor Preserved. So let's first go over the Emperor Reduced trial. They came out last year. Patients were randomized to empagliflozin or placebo, 10 milligrams, and followed for long-term outcomes. Here are the primary results. As one can see, the curve started separating early, continued to separate towards the end of the trial. Very statistically significant and very clinically meaningful 25% relative risk reduction, number needed to treat of 19, absolute risk reduction of 5.2. These trials, the entire program, Emperor program, was designed to answer three questions: cardiovascular death, heart failure hospitalization. If that is positive, total heart failure hospitalization. If that is positive, then renal function preservation or eGFR preservation. So because we met our first endpoint, we move on to the second endpoint, which was total heart failure hospitalization. And total heart failure hospitalization was reduced by 30% relative risk reduction, again, very statistically significant, which leads us to the third endpoint. And the third endpoint was renal function preservation. Remember that when we start ACE inhibitors or ARB, these drugs are kidney protecting drug, but when we start them, because of intraglomerular hemodynamic, you see a little bit of a change in GFR, a bump in creatinine. You stop these drugs and then that change comes right back. That is not kidney damage. That's actually just hemodynamics. And in the long run, these drugs are beneficial. SGLT2 inhibitors are exactly the same, that you're seeing this initial drop in the GFR, and then the renal function starts getting preserved. Also notice that the placebo arm, is not that we weren't doing anything to these people. 90+% of the placebo arm were on RAS inhibitor, and 70+% of the placebo arm were on MRA uses, mineralocorticoid receptor antagonists. So this is the decline, ongoing decline, despite that background therapy. This translated into a 1.73 ml per minute per year renal function preservation. In other words, the empagliflozin renal decline over time was decreased by 1.73 ml as compared to placebo. And that led to a pretty substantial reduction, a 50% relative risk reduction in the composite clinical kidney endpoint result, which was a decrease in 40% of eGFR or kidney transplant or dialysis or death, etc. Now, remember this number, 40% reduction in GFR, because this becomes important, and we'll discuss this again in a minute. Our patients want to live longer and live healthier, so quality of life becomes important also. So we measured that at 3 time points, earlier at 3 months, and then 8 months, and then 12 months. And as one can see, the benefit was accrued right when we measured it the first time, and it was sustained quality of life improvement all the way towards the end of the year. Did our experiment work? Whether diabetes or no diabetes makes any difference? The answer was absolutely not. Now, Emperor Reduced and also DAPA-HF clearly prove that regardless of diabetes, both patients with and without diabetes improve their outcome, and that these are cardiovascular risk modifying agents. And then the last thing also is that in the clinical practice, we have a lot of inertia. We see the patient, we say, well, you're doing okay. Why don't I see you back in, 3 months or 6 months, and we'll change some medication. Here, the Kaplan-Meier curve was statistically significantly different at day 12. So in less than a month, you start seeing these benefit, and we need to therefore not only apply these therapies, but the sooner we apply, the better it is. So that then leads us to Emperor Preserved trial. Emperor Preserved, same design, but EF greater than 40%. So first, I will go in a little bit more detail because this is the new trial out just 2 weeks ago. So the first thing is that we ended up with a patient population that surprisingly was actually at a little bit of a lower risk than what we were anticipating. So we anticipated kind of both trials, Emperor Reduced, Preserved, to have about a 15% annualized event rate of 15%, 100% year event rate. In Emperor Reduced, we ended up going on the other end. We got a risk of about 20%. Here, as you can see in the placebo arm, the risk was only 8.7 per 100% year follow-up. That was substantially improved with the use of empagliflozin, 21% relative risk reduction. I would say that if I were to not put the two EMPEROR-reduced and EMPEROR-preserved curves side by side, it will be difficult for you to say which one is EMPEROR-reduced and EMPEROR-preserved. Really remarkable, same benefit, early separation of the curve and continue to separate. Some of the subgroups are very interesting in patients with HFpEF and HFrEF. We really don't care about subgroups, right? We know regardless of which characteristic you belong to, if a therapy works, it works. In HFpEF, there's a lot of interest about sex interaction, that maybe women benefit more versus men. There is this whole issue of diabetes, ejection fraction, etc. So here, as you can see, baseline renal function did not matter. GFR more than less than 60 did not matter. Diabetes, no diabetes, ditto, same point estimate, no difference, both group benefited. Sex, no different, both men and women benefited exactly the same. Ejection fraction, again, for the primary endpoint, we saw no difference, p-trend of greater than 0.2, and as you can see, all three groups were benefiting. Meeting our first endpoint, we move on to the second endpoint, which is total heart failure hospitalization. Again, the curve separated very early, continued to separate, 27% relative risk reduction, which then leads us to our third endpoint, and our third endpoint was GFR, and the GFR preservation was 1.36 ml. So in EMPEROR-reduced, we said it was 1.73 ml, and here it was 1.36 ml. Again, very statistically significant result. But on the right hand, if you look at it, the major clinical renal endpoints like dialysis, transplant, whatnot, that did not statistically significantly differ. So now it becomes an interesting question that in EMPEROR-reduced, you saw renal clinical endpoint benefit, and in EMPEROR-preserved, you did not. What does that mean? Well, there are several interpretations. One is that you need 1.73 ml benefit, not 1.36. 1.36 is not enough. That's one interpretation. The second interpretation is that all that we have learned about about SGLT2 inhibitors and diabetes trials and chronic kidney disease trials and HFrEF trials where these drugs preserve renal function, all of that is not applicable to HFpEF. That HFpEF is just completely a separate entity. And I would say that the answer is third. It's completely different, and I'll give you my answer. So first of all, I don't think it would make any sense that SGLT2 inhibitors preserve renal function and improve renal outcomes in all this diabetes cardiovascular outcomes trial, in all HFrEF trials, in all CKD trials, and all of a sudden, there is something so dramatically different about HFpEF. So that doesn't make sense. Second, what about this 1.36 being not enough? So this is the meta-analysis of 47 randomized controlled trials over 60,000 patients. And what we find is that if you preserve eGFR slope by about 0.75 ml per minute, 0.75 ml per minute, and follow the patient, you almost have 100%, 96% probability that you will improve the outcomes. And in EMPEROR-reduced, it was 1.73. In EMPEROR-preserved, it was 1.36, almost double of that threshold. So to say that 1.36 is not important, that doesn't make sense also. So how do you explain the results? So this is my interpretation. I'm sure you may have a different interpretation and we can argue. The problem here is with clinical trials is that they are so expensive that you only get one shot to make your decisions. You know, if you're a basic scientist and you're doing experiments on lab rats and animals, you do an experiment. If it's a success, great. If it's a failure, you learn lessons, you change your experiment, and you do it again in a different way. You don't get that option in clinical trial. So what's the problem here? Remember that patients in chronic kidney disease trials, they are enriched to get kidney outcomes. When we do heart failure trials, these patients are not enriched for kidney outcomes. So the question is, how do you get more kidney outcomes so that you can get a sense what is the kidney effect? In heart failure patients, suppose if you are decreasing your GFR between 1.5 to 2 ml per year preservation. So the placebo arm to go from, say, 60 to 20, and you start talking about, dialysis, that will take 15 years. You don't do trials for 15 years. You do trials for 2 or 3 years. So how do you do it? There are people out there that very strongly propose that the GFR threshold for benefit should be 30%. The problem with 30% is that when you give ACE inhibitors or when you give SGLT2 inhibitors, you already have a GFR drop because of intraglomerular hemodynamic benefit. So with 30%, you will have a lot of noise. So we were not in favor of it. Other people will go to the other extreme and say use 50% or 57% because you'll get very accurate data and you won't have noise, and which is absolutely true. The problem is that in a heart failure trial with patients not enriched for renal endpoints, in 2 years, nobody will reach the 57% threshold and you won't have the events. So how do you deal with that? So in retrospect, it is what it is. You try to do your best. And we went with the middle. We did not use 30 for noise. We did not use 57 for power. We used 40. And the bottom line is that we ended up getting more noise with 40% in HFpEF than we were expecting. So we decided to do a secondary analysis using a 50% reduction in eGFR as an endpoint. And all of a sudden, your hazard ratio moved from 5% to 22%, 22% relative risk reduction in clinical endpoints. Remember, the confidence intervals are wide, they cross 1. I realized that, but also realized that the number of events went down to over 200 to a little over 100, were decreased by 50%. So the bottom line is, in my estimate, and I want to be very careful to say this, these are all secondary analyses, and these are my opinion. I think in my estimate, there is no difference in renal benefit in HFpEF or HFrEF or diabetes or chronic kidney disease. They're all showing us the consistent benefit. 1.36 is a pretty substantial benefit. It's a definition issue and the number of events issue, in my opinion. Also, if you look at the renal benefit and divide the patient with different ejection fraction ranges, you start seeing that the patients who are more like HFrEF really have a pretty substantial benefit that we are seeing. Quality of life, again, very similar benefit. Early benefit was seen and that benefit was sustained over a 1-year period. Another way to look at it is to look at what we call responder analysis. So for our colleagues and friends who don't think about KCCQ all the time, what basically it is there are 3 domains. So one is symptoms, which is called in the middle here on the left, TSS, total symptom score. So that is symptom frequency, burden, and severity. If you add physical limitations to it, so symptoms and what you can and cannot do, then it becomes CSS or clinical summary score. And on top of that, if you add sexual function, social integration, quality of life, then it becomes overall summary score or OSS. If you look at different thresholds for improvement, 5-point improvement is clinically relevant. 10-point is really robust improvement. 15-point is really, really robust improvement. Doesn't matter whether you look at CSS, TSS, OSS. Doesn't matter whether you look at 5-point, 10-point, 15-point. Doesn't matter whether you look at 12 weeks, 32 weeks, or 52 weeks. At all time points, the odds of improving with SGLT2 inhibitor was higher than with placebo. Conversely, if you look at the worsening by 5 points for any of these scores, that was higher with placebo than with empagliflozin. Nothing on this slide, really. We know this for a long time with SGLT2 inhibitor, no surprises. The one thing that I will mention is, again, we are clinicians, so we need to use our best clinical judgment at the bedside. So we should not take, 4,000, 5,000 patient trial average results to the bedside. We should use our best judgment for the patient sitting in front of us. Having said that, overall in the population, there was not much effect on blood pressure, about a 1.2 mmHg difference. And really, patients did not require diuretic alterations or other medications alterations and stuff like that. Again, if you have somebody who's older, who's orthostatic, you would individualize the therapy, but overall, we were not seeing much effect. Now, this slide is really fascinating, and this is the safety and the tolerability. And the reason why I find it really fascinating is that, whenever new trials, new drugs come out, not only are there risks, but we don't know how to use those therapies. And as over time we learn how to use those therapy, we get smarter. And the minute we get smarter, the drugs get safer. So here, if you look at this slide, the overall safety profile, really no surprises. All the things that we know from the previous literature, the total adverse events or serious adverse events were lower with empagliflozin than placebo. No, signals for amputations or fractures or this, that, the other. I mean, pretty similar to what we were finding. Genital myocardic infection was higher with empagliflozin, 2.2% versus 0.7%. But we have known that the genital myocardic infections are higher with SGLT2 inhibitors. We have seen that in pretty much all trials. And therefore, it's really important to take care of genital hygiene, keep the area clean and dry. What I find really fascinating is not that there was a higher risk of genital myocardic infection, but look at the absolute risk. Now that from the diabetes trial 5, 6, 7 years ago, clinical use, now that we give people these instructions, we know how to use these drugs smarter, the absolute rate, even if it's higher with empagliflozin, the absolute rate is 2.2%, whereas it used to be 5, 7, 8%. So again, if we take some cautions, and the biggest example of this caution is look at ketoacidosis and hypoglycemia. Sorry about that. Ketoacidosis and hypoglycemia. There were no differences. There were no differences between the two arms. Now, I think it is not a good interpretation to say, oh, with SGLT2 inhibitors, don't worry about ketoacidosis and hypoglycemia. That would be the wrong interpretation, although in this trial, we found no difference and almost no cases of ketoacidosis. Again, this is a function of us taking care of it. So you will almost never, or maybe definitely never, get hypoglycemia with SGLT2 inhibitor if you're using it alone or with metformin or DPP4 inhibitors or GLP-1 receptor agonists. It only occurs if you're using secretagogues, sulfonylureas, or insulin. So if you adjust the doses of those medications and take precautions, then that risk goes away. And for ketoacidosis, yes, there is a small risk. The bigger risk is actually not the risk of ketoacidosis, is that we diagnose it late. So if a person calls you who has diabetes, who's saying, I'm not feeling well and I'm vomiting or whatnot, and you check their you check their glucose levels. If their glucose levels is 600, we ask them to check their ketones. The problem is that with this drug, you excrete glucose in the urine. So they develop ketoacidosis, but their glucose level may be 200. And we don't think about it. So the diagnosis was delayed till somebody got really sick, came to the emergency room. Now that we have gotten smarter, just like the genital myocardic infection, if somebody's hemoglobin A1C to begin with is 7 and we are starting this therapy, we will cut back on their other therapies. Somebody is on insulin, cut down the dose by 30%. You give patients the instruction. It's, if somebody is going to be NTO before surgery, if somebody has diarrhea, is not eating, hold the empagliflozin for 2 days. By doing these small tricks, look, we did not find any difference in hypoglycemia or ketoacidosis risk. So the bottom line is that I apologize. I'm using a new computer, so these graphics are a little bit messed up. But the bottom line is that this trial for Emperor Preserve was designed to answer these 3 questions: cardiovascular death, heart failure hospitalization, total heart failure hospitalization, and renal function preservation. All 3 of them were achieved highly statistically significant and clinically relevant in Emperor Reduced and in Emperor Preserved, both trials. So to put them in perspective, this is Emperor Reduced as compared to the other recent trials that we have seen in patients with heart failure and reduced ejection fraction, comparable or better hazard ratio, absolute risk reduction, and number needed to treat. And if you look at now Emperor Preserved trial with other heart failure with preserved ejection fraction trial, by far this is the first unequivocal positive trial in patients with heart failure and preserved ejection fraction. And if you put the 2 trials side by side, one sees almost no difference between the 2 in any of the outcomes which was studied, and we can use the therapy across the spectrum of patients with heart failure. Now, the guidelines were recently updated. The American guidelines are not updated. The European guidelines just came out 2 weeks ago, and they have already now recommended SGLT2 inhibitor, evidence-based empagliflozin and dapagliflozin as foundational therapy. So RAS inhibitor, beta blocker, MRA, and SGLT2 inhibitor are foundational therapy for heart failure with reduced ejection fraction. All patients with heart failure, reduced ejection fraction, unless contraindicated, should be getting this. The heart failure with preserved ejection fraction trial results actually came out when these guidelines were written. So we will see more coming out of that in the future. As I said, in US, the guidelines are not out yet, but the American College of Cardiology already came out with an expert consensus pathway document, which also recommends SGLT2 as a foundational therapy. Now, in the last section of my presentation, moving on a little bit towards practical use. So in heart failure with preserved ejection fraction, there is no sequencing, right? This is the first trial that is positive, and the patient should be treated with empagliflozin 10 milligrams. But in heart failure with reduced ejection fraction, there is a lot of inertia. So we start a person on ACE inhibitor, and then we get them every 4-8 weeks in the clinic. We go up on the dose, then we go to beta blocker, then we switch to ARNI, we start MRA, then we do that. What ends up happening is it takes months and months and months and months to get people on the right medical therapy, and all across the globe, US, Europe, Asia, India, wherever you look at it, most of the patients with heart failure, reduced ejection fraction, big inertia are not on optimal medical therapy. Not on optimal medical therapy, just yes, no, and certainly in case of yes, not on optimal doses. So this is a big problem. And on the other hand, we also know that if you were to give these combination therapies, you are talking about an excess of 8 years of survival. So we are not talking about something where the survival difference, like in cancer therapies, have few weeks or few months. We're talking about years and years of survival benefit, and yet we are not moving on with the therapies as soon as possible. And this becomes especially important because I showed this slide, the benefits accrue pretty early. So there's a lot of folks out there that are focusing on the fact that evidence generation is great, but evidence implementation is also very important. And remember that sequencing of therapy is a historical construct, not a biologic construct. It's history of medicine that in the 1980s and 1990s, we checked ACE inhibitors, and then late 1990s, we assessed beta blockers, and then we test MRAs and ARNI. This has nothing to do with biology. There's no biologic rationale that you give this first and that second and all that kind of stuff. So there's a lot of focus that forget about sequencing, forget about even the dose. Now remember, dose is not an issue for SGLT2 inhibitors or MRA. It's 25 milligrams and 10 milligrams and you're done. But dose is an issue for beta blockers and RAS inhibitors. But the biggest bang for your buck that you get is when you initiate the low dose therapy. I'm not saying give low dose therapy and forget about it. Yes, go up on the dose, but at least cover all the 4 major pathways as soon as possible when you can, and then take your time in up titrating the doses. So this is a sequencing for HFrEF that Dr. Packer and McMurray has recommended. So they suggest that beta blockers are really good for heart failure with reduced ejection fraction, but because they have initially some negative inotropic effect, if you marry them with SGLT2 inhibitor and their diuretic effect, that will be great, and then move on to ARNI and mineralocorticoid receptor antagonist. I had the pleasure of writing this with Dr. Greg Fonarow, and we were sort of arguing that if we can start 6 new medications in patients with MI, heart attack, in the hospital setting in 2 days, why does it take months and years in HFrEF? I realize that in-hospital is different than outpatient, but what we were recommending is that we really don't care about any sequence. Use the phenotype of your patient and your clinical acumen to decide. Somebody's potassium is high, somebody's creatinine is high, somebody's blood pressure is low, somebody's heart rate is low. Use your best clinical judgment, but just at least get these 4 drugs on board as soon as possible, and then titrate as needed. At least put all the 4 drugs within 4 weeks on the patient. Now, one question that always comes up, and everybody sort of keeps asking this, is that we were all used to all generic drugs in heart failure, right? So captopril and carvedilol and spironolactone, everything was generic. And now all of a sudden, ARNI is not generic, and SGLT2 inhibitor is not generic. Costs are an issue. So which one do you choose if you have to choose one or the second? So I would say, first of all, we should talk science before cost. This is not to say that cost is not important. Obviously, I practice in Mississippi, which is the poorest state in the United States, and cost is really, really important. But the reason why I very strongly say that let's talk science first before cost is a matter of time. In several years, all of these drugs will become generic. ACE inhibitors and beta blockers were not generic at one time. So SGLT2 inhibitors and ARNI will become generic. So let's get the science right first. We'll have several years to deal with whatever the best we can, and then we'll become generic. But let's get the science first. So scientifically, there is no way for me to answer the question to choose ARNI or SGLT2 inhibitor. You've got to use both of those things. However, till we get to that point where everything is generic and when we can use it, if you have to choose one, this is entirely my opinion. So if you were to design an ideal heart failure with reduced ejection fraction drug, you would say, well, it's a once-a-day drug. There is no titration, improves clinical outcomes, improve quality of life outcomes, can be initiated and benefit is seen relatively early, is safe and well tolerated, does not affect blood pressure and potassium and heart rate and all those kind of stuff, and it's affordable and accessible. And I would, on top of that add also have multi-organ benefit, cardio, renal, metabolic, glucose, glycemia, pre-diabetes, all of those kind of things combined. That the last bullet, affordability, other than that, SGLT2 inhibitors fit every single one of this thing. And I think it would make sense to give SGLT2 inhibitors. But I say this with a lot of trepidation. Ideally, you should really give both, but that's a benefit. This is my last slide, and I want to end up on sort of a little bit of a appeal, if you may. We all say that heart failure has outcomes as bad as many forms of cancer. Sure, pancreatic cancer, small cell lung cancer have much worse prognosis, but other cancers like breast cancer and prostate cancer and colorectal, bladder, whatever, their outcomes are very similar to patients with heart failure. I also heard our moderator in the beginning of the presentation say that in India, the 5-year mortality rate is about 60%, again, higher than many forms of cancer. Why is there so much urgency for management of cancer, appropriately so, and we jump at it when even the therapies have so much toxicity, therapies cost so much, and the benefit usually accrues in a few months? Here, the costs are high as compared to generic, but as compared to cancer therapy, the costs are much low. The benefits are in terms of years, not in terms of months. And yet there is this inertia that we don't give patients appropriate therapy. This obviously is not to be juvenile and childish to say that, heart failure is more important than cancer. Of course, we need to treat cancer very aggressively, but I think we don't focus on heart failure as aggressively as we should, and maybe we should. So I will stop here. I very, very much appreciate the opportunity to talk to all of you, and my apologies that I had requested you to start this 15 minutes early. Thank you.
Thank you very much, sir. Thank you for the excellent and detailed discussion on the trial, the background of the trial, how from an investigator point of view, you have dissected the endpoints, especially the renal endpoint, how that small change in the renal endpoint makes a significant outcome difference, that way we perceive the outcomes. I think it has been really good, because those were some of the very questions that was coming to our mind as to why Emperor Reduced did not show the heart renal endpoint benefit, whereas Emperor Reduced showed it. So I think that is very well taken care by you in your presentation. So that's really good. And what we'll do is I'll just have Dr. Sanjay Mittal give a few points, and then Dr. Mrityunjana give a few points, and then we will go for the audience questions after that.
Yeah.
Dr. Sanjay, please tell us
a wonderful
your take on the thing.
Thank you. Am I audible? Yes. So it was a wonderful deliberation. Thank you, and thank you for enlightening us on all the literature running from the A to Z of SGLT2 inhibitors. Wonderful. A few of the things is that it's exciting for all of us cardiologists. For the first time, we have a drug which has shown primary endpoint outcome benefits in heart failure with preserved ejection fraction. But there were a few things which I still am able to not analyze. And I think Dr. Butler would possibly be the best person to enlighten us on this. For the first time in those heart failure with preserved ejection fraction trials, the ejection fraction of the enrollment was 40% or above. In the rest of the HFpEF trials was 45% or above. And if you remember, even the ARNI trials, Paragon, it was less than 57%. There was a benefit in primary outcomes as compared to more than 57. And even this trial, Emperor preserved also, if you look at the outcome benefits for 27% risk reduction in people less than 50%, 50 to 60% was 20%, and above 60%, it was not substantial significant. So, I mean, is it the benefit in this particular trial because of lower ejection fraction enrollment, or otherwise, if you can explain that?
Yeah, so very, very insightful question, and happy to. So first, there is a big debate as to, okay, let me take a little bit of a long road to answer this question. So how did we come up with this disease called heart failure with reduced ejection fraction? This all started with J. Cohen days. And at that point, we were only giving in the 1970s and 80s diuretics and digoxin. We had nothing else. They said that, vasodilators may be good because a lot of the heart failure patients are vasoconstricted. So in the 1980s, we were doing trials with nitroprusside with hydralazine nitrates. And it's difficult to put a Swan-Ganz catheter on every patient. So they said, well, let's try to figure out who are the patients with heart failure who are more likely to have hemodynamic abnormalities, more likely to have vasoconstriction. And they said ejection fraction less than 35%. So that's how we created a disease called HFrEF, or ejection fraction less than 35%. But then when the solved investigator, ACE inhibitor, they kind of moved it to 40%. I assume they moved it for practical reasons. They wanted some more patients. But there was no sort of other reason to differentiate, but that was the reason they differentiated 40. And then when we moved away from vasodilators to neurohormonal therapy, there was a history set, and everybody kept on doing trials with 40% or less. That just became history. Okay. Then when we realized that, half the patients who develop heart failure have EF more than 40%, what do you do with that? And that was really difficult because we know that normal ejection fraction is 50-55% plus. So if you were to truly do clinical trials and heart failure with normal ejection fraction, you would include patients with EF 50-55% or more. The problem is that then you have this 15% of the people between 40 to 55% that we will never have any evidence. So when the CHARM investigators planned their candesartan studies, they said that they will go for everybody over 40%. And I apologize, there's a lot of history and nuance, but maybe it will be interesting to our audience. So they went with an EF of greater than 40% and deliberately named this entity heart failure with preserved ejection fraction, not heart failure with normal ejection fraction, because they knew they were including people that don't have normal ejection fraction. From there on, everybody is struggling how to do trials. So DAPA-HF, Emperor, so dapagliflozin Emperor, we went to 40 like candesartan. Valsartan, sacubitril, Topcat, they went to 45. There's all of this sort of struggle what to do. That raises a very important question that you mentioned, is the benefit in this 40 to 50% range the reason why these trials are positive? Because basically you're calling it a HFpEF, but it's basically an HFrEF enriched trials. So again, if you look at the outcome, and there is a secondary paper coming out, we looked at it very carefully. What we are seeing are two differences from TopCat and from Paragon HF. Paragon HF and TopCat both showed benefit in mildly reduced ejection fraction, 55 or less. Yeah, 57 is what their cutoff was for medium, but 55 or less. And that's why the FDA indication also says it's indicated for chronic heart failure. Benefits are seen in heart ejection fraction less than normal. The second thing they also saw was a strong sex indication interaction, that women benefited more and men did not. What we are finding in Emperor Preserve, that while the interaction test is negative, as you mentioned, if you look at 40 to 50, 50 to 60, greater than 60, there is a decrement of risk. So we did a splines, continuous analysis to see where do you lose the benefit. And what we are finding is that there is consistent benefit up to ejection fraction of 65% without any difference in men and women. Okay. So then the question is, this 10% of the population, ejection fraction greater than 65%, why are they not benefiting? So you will need to invite me again for a presentation in about 3 months, and I can get you more insights. But what I can tell you today, we are looking at it very carefully, and it turns out that patients with ejection fraction greater than 65% had the highest proportion of women, lowest EGFR, highest atrial fibrillation, and oldest patient. All 4 of these characteristics would tell you that their NT-proBNP levels will be very high, right? Low GFR, atrial fibrillation, age, and women. And yet, their NT-proBNP levels were barely elevated. So what we feel is that there is a lot of HFpEF mimickers. Somebody came in with atrial fibrillation, was short of breath, and they said, oh, HFpEF, put it in the trial. Maybe amyloidosis and all that kind of stuff. So our interpretation is that empagliflozin works definitely up to the ejection fraction of 65, but we need to understand more what is happening more than 65, and I don't know all the details today. I really apologize for the long answer, but there's a lot of history here.
That's great. Quite interesting.
Dr. Mrityunjay.
In fact, hello.
Hello, sir. You're audible, sir. You're audible, sir. Please tell us.
Webinars and in fact, last night I went through his webinar involving this preserved ejection fraction trials in Medscape. My question was also in the same line. In TopCat or emphasis heart failure, for that matter, Paragon heart failure also, all the trials showed that those who had lower ejection fraction, the strata of ejection fraction subgroups, the lower ejection fraction group benefited from the drugs. So is it possible that those were the patients who were truly, let us say 45% or 42% ejection fraction, they are truly heart failure with reduced ejection fraction, and they had improved to the class of heart failure with mid-range ejection fraction. And all the trials, in fact, the CHARM preserved trial also showed that there was not much benefit, but later on, the subgroup analysis showed that there was some benefit definitely. So what do we make out of it? And second question to Professor Butler is that there was serious adverse events has been mentioned to the tune of 45-47% in this Emperor preserved trial. What does that mean? What type of adverse reaction? I mean, 50% people having adverse reaction. Is it true, or you have included some minor problem related to the drugs? These are the two questions I wanted to ask.
Yeah, so both very good questions. So remember, we are doctors and nurses and clinicians, and we should be careful not to let the statisticians take over the world and tell us how to practice medicine, right? So all of this jargon about secondary analysis and post hoc and this, that, the other, yes, there are good reasons to have statistical rules. But as a doctor, I would say that the so-called universal definition of heart failure is already obsolete. So this whole issue that HFrEF is less than 40% and mid-range is 40 to 50% and HFpEF is greater than 50%, I think this ought to just go. I think we should basically say that anybody's ejection fraction less than 50% is HFrEF, period. Just it's HFrEF and that's it. I would not be surprised because in women, the normal ejection fraction is 54% plus minus 5, and in men, 52% plus minus 5. It may even be reasonable looking at TopCat or Paragon results to call HFrEF less than 60%. Truly, any time, even if there's mild reduction, just call it HFrEF and keep HFpEF to that greater than 60% category. So my bias would be that at this point, definitely anybody with ejection fraction 55% or less should be really given the quad therapy that we give for HFrEF. And anybody with heart failure syndrome with ejection fraction all across the spectrum should be given empagliflozin, and let's wait for the DAPA trial to come out and see what we learn in that higher ejection fraction. So that's what we will be today. Now, the SAE question is really important. So remember that in our clinical practice, 80% of the patients don't have adverse events and 40% of the patients don't have serious adverse events, right? So it doesn't make any sense. Well, that is because the clinical trial, the regulatory authorities have very strict definitions, and they just said any time that you had to change any medications during the trial with or without relationship to the investigational therapy, you have to report it and let then the blinded people sort of figure out what to do. So you took NSAID for arthritis, and then your potassium went up. You had diarrhea, so you cut down your dose of Lasix for 3 days. All of those things are noted in regular medical practice as AEs, SAEs, and not only cardiovascular. You had flu and you had cough and you took, some cough syrup. Everything is noted so that then we can look at it in the blinded fashion, make sure that it's equal between placebo and treatment, and there's nothing coming out. So these numbers are very big because everything that happens to the patient is reported. So what you want to look at is what's the difference between the treatment arm and placebo arm.
Dr. Butler, can I ask you a question also?
Yes,
it's
sir.
also related to this mildly reduced or ejection fraction and all. We do know that majorly the benefit in the primary endpoints was because of hospitalization and heart failure reduction in Empiric Preserve. Mortality benefit, unfortunately, did not in itself show a benefit. And that is almost like rhyming to all the other trials, maybe Paragon HF and TopCat, as you very rightly said. So that is one of my questions, why do we not yet see the mortality benefit? And do you have a sub-analysis where you did see some benefit or some trend to benefit in a lesser ejection fraction as compared to higher ejection fraction? That is one of the questions. And the second thing which I always relish is the paper which I read about a couple of years back, that heart failure with preserved ejection fraction, is it actually a renal disease rather than a heart disease, which would mean all those drugs, TopCat, including MRAs, ARNIs, which have also a diuretic property, and SGLT2 inhibitors, have shown benefits in heart failure hospitalization because of their diuretic effect rather than any other thing. So these are the two things which I just wanted to ask you.
So you're asking incredibly insightful questions, and unfortunately, I have answers, but long answers. So sorry about that. So let's take the second one, which is easier, and the first one is more technical. So in terms of the NT-proBNP reduction with SGLT2 inhibitors is really minimal and would not explain the benefit in terms of the diuretic. Also, the MRA use. MRAs, the natriuretic properties is at 200 milligrams of spironolactone. At 25 milligrams, you see nothing. So these are other effects. So the renal benefit is certainly there. And I think that sometimes, our academic colleagues get too academic and too much sort of stuck to their point of view. It's a heart disease, it's a kidney disease. At the end of the day, the body is so integrated that it's a composite of everything. It's both the heart and the kidney together, but the kidney benefit is about decreasing, so you have increased sodium delivery to the gestoglomerular apparatus, so you have increased tubulogranular feedback, you have afferent constriction, efferent dilatation, decrease intraglomerular pressure, and by decreasing intraglomerular pressure, you have renal function preservation and decreased fibrosis and so on and so forth. So yes, it is a renal disease in part. Yes, there are renal benefits, but it's not because you pee a little bit. Otherwise, the heart failure world would be cured just by giving Lasix and then you're done furosemide and you don't need anything else. Now, the first answer is really, really, really interesting. So you are giving me an opportunity to give completely my opinions. I cannot prove anything that I'm about to say. So let's think about it. Does it make any sense for a drug to reduce hospitalization and not reduce mortality? Because hospitalizations are the precursor to mortality. You're developing worsening heart failure, you keep coming into the hospital, you develop cardiorenal syndrome, and then you die. So how can a drug, whether it is empagliflozin or whatever, how can a drug reduce hospitalization by 20, 30% and have no effect on mortality? To me, it makes no sense. So then we need to try to understand. Remember that in the 1980s and 1990s, we did trials where primary endpoint was mortality. And we did the trial as long as it takes to see whether there is mortality benefit or not. Because of the global nature of trials and the cost of trials being so high, from about 2000s or so, about in the past 20 years, we said, well, hospitalization equals to eventually mortality. So why don't we make a composite endpoint of cardiovascular death and heart failure hospitalization, right? Now, what happens is that you design a trial and you say that this is an event-driven trial and we'll stop the trial when 800 events are accrued. In 1980s, that means you wait for 5 years to have 800 mortality. In 2020, you still have the 800 events, but you can say, we don't care whether it's mortality or hospitalization. Now, what's going to be more common, hospitalization or mortality? Of course, hospitalization. So the trial still stops at 800 patients, but out of 800, 500 are hospitalizations and only 300 are mortality. Even that is not a problem. The problem is that the follow-up is very short. So these trials, Victoria trial had 10.6 months of follow-up. Emperor Reduce had 16 months. Emperor Preserve have 2 years. We don't do trials for 4 or 5 years. So unless and until there is, you are using beta blockers with significant effect on sudden cardiac death. When you use drugs like SGLT2 inhibitors that cause reverse remodeling, that progressive pump failure benefit will require you to wait out for 3, 4, 5 years to see those benefits, but we don't do that and we stop the trial. So my interpretation is that the 9% cardiovascular mortality benefit, which was congruent, if you were to do this trial for 4 years or 5 years, you will see the mortality benefit. It makes no sense, and it is entirely an issue of how we design trials right now. Now, this is my opinion. I cannot prove it to you, but that's at least the way I see things.
Lovely. I think that's a very pertinent point, I think.
My one question, Professor Butler, there are hardly any head-to-head trials between DAPA and empagliflozin, except one Taiwanese trial is there. So if you are given an option in a patient with heart failure and reduced ejection fraction, which molecule you will prefer? Will you prefer DAPA or EMPA?
Yeah. So I actually don't even know who's sponsoring this program, but I can give you my opinion. This becomes a really important issue. So as a doctor, as a clinician, I would love to say it's a class effect. Just give anything that is available to you. The problem is that we get stuck with this when we have done that in the future. So for instance, even in the diabetes trials, with DPP-4, with saxagliptin, you increase heart failure risk. With alogliptin, also it's in the wrong direction, but with linagliptin and sitagliptin, there is no problem. Beta blockers, carvedilol, long-acting metoprolol, bisoprolol improved heart failure outcome. Nebivolol and bisindolol did not. So there are these differences between molecules within a drug class that just saying that use any drug in the class is difficult, and we should really stick to evidence-based drugs. So there are SGLT2 inhibitors that have never been tried in patients with heart failure. So I would definitely stay away from them. But that's not the question you're asking. You're asking the question, both DAPA and EMPA have been tested in heart failure and they're beneficial. My opinion is it's interchangeable, whatever is available to you. I don't think that either one of them is superior or less superior. You see these things, EMPEROR Reduce hit the renal endpoint p-value, DAPA did not. DAPA hit the cardiovascular mortality p-value, EMPEROR did not. All of these are power and statistical issues. Honestly, either one of them is good enough.
A comment on sotagliflozin. I think that was an unceremonious departure of the drug. Any comments on that?
It is really sad. It is really sad because SGLT2 inhibitors have a lot of cardiorenal benefit. The vascular MACE benefit is modest and the stroke benefit is not seen. With sotagliflozin, which is an SGLT1, SGLT2 combined drug, there is a potential because remember in the heart, there are no SGLT2 receptors, but there are SGLT1 receptor. The only problem is that it was supposed to be a 5,000 patient trial. It only stopped at 1,000 patients. Yes, it was positive, but we have been fooled by smaller trials a lot in the past, and we don't have a full trial data. So I don't know what to say. I don't know what to say. It's really a shame that we don't have a full trial.
Another question from the delegates is regarding the subgroups of heart failures and who are the subgroups who will benefit more or who are the population. Like we saw a lot of Asian population was benefited slightly more than the other populations. So are there any subgroups who benefit more or less, whether it be etiology of heart failure with preserved ejection fraction like prior atrial fibrillation, obstructive sleep apnea, prior stroke, or what are those kind of people who benefit better and the population?
So some of these subgroups we haven't looked at. All the pre-specified subgroups that were pre-specified, about 12 subgroups, so GFR, obesity, sex, this, that, the other, we saw absolutely no benefit. Ischemic, non-ischemic hypertension, no hypertension, baseline therapy with RAS inhibitor, beta blocker. I mean, none of that made any difference. So I would say at this point, if you make the diagnosis of heart failure, unless and until it's heart failure because of aortic stenosis or heart failure because of sarcoidosis, but the generic heart failure really doesn't matter what your EF is. I think we have the data with empagliflozin.
Is there any role for gene typing or any other specific things to?
We have a lot of blood, and we intend to do a lot of biomarker omics-based analysis. Not single marker, but multi-marker omics-based analysis. But I mean, we are 6 months from here, so 6 months, 8 months. So you will definitely need to invite me again for that. But I don't have any data today.
Some of the comments that we wanted from you is it was a very nice and well-matched trial where there was a significant amount of beta blocker usage, significant amount of ARNI, ARB, ACE inhibitor, RAS usage, RAS ARNI usage, and everything. In spite of that, we got a significant benefit. So how do you look at it in our Indian perspective as to where we have a lot of population of diabetes, a lot of precursors of these risk factors for future heart failure? So when do we start? Do we start even before they have a heart failure? And
definitely. So I don't have any data in patients without diabetes, but patients with diabetes, these drugs prevent heart failure. Absolutely. So I wouldn't wait for development of heart failure. If you have type 2 diabetes, start the drug regardless whether you have heart failure or not. But in terms of heart failure, in HFrEF trials, you can say, well, this is the standard of care, so you give this. In HFpEF, there is no standard of care up until now. So we are lucky that all these comorbidities of coronary disease, hypertension, whatnot, led to a very high use of ACE inhibitors and beta blockers. So at least we are certain that all the benefits is incremental to all the other therapies that were given. I have to apologize. I'm getting text messages and they're freaking out downstairs because I need to go on the podium in about 7 minutes. So I'm going to run, but feel free to, if somebody Googles my name, my email address is there. I'm happy to answer any questions or get back to you as well. And thank you so much.
Thank you, sir. Thank you for your valuable time and inputs. And,
okay.
Thank you. Thank you.
I will not hold you
Fantastic.
back too much. I think we are all very glad that you are here for us and give us all the insightful comments plus the amazing presentation. Thank you very much, sir.
Thank you. Bye-bye.
Thank you. Thank you.
Thank you, Dr. Butler, and thank you all the respected panelists. It was a really insightful discussion. And
Dr. Sanjay, you want to give some closing comments for our audience?
For sure. I mean, I would request closing comments from all the Indian panelists also. I'm sure that a lot of us are watching this live here, all the doctors, and it would be really great.
Yeah, so thank you, Doctor. It was a wonderful lecture and a wonderful interaction. My take home is that I'm excited about having a molecule which is being tested as positive for improvement outcomes, primary outcomes in heart failure with preserved ejection fraction. There are always going to be questions, and we are going to eagerly wait for the delivered trial results to see whether it is supportive of the observation of Emperor preserve. The fact dapagliflozin or empagliflozin for us has been just shuttling with each other. Once one thing, the Empiric trial was in favor of empagliflozin as far as mortality and primary endpoints. Declare was not. But then DEPA-HF was in favor of heart failure outcomes. Emperor was also the same thing. Mortality was not. But Emperor preserved is first trial to show benefit in preserved ejection fraction. I think we are very keen to wait for the results of deliver. I believe that after that, we hope that we'll have a first class 1 indication for heart failure with preserved ejection fraction.
Dr. Mrityunjay.
I don't think there is anything to it. The last comment of Professor Butler, I agree. Any patient who is diabetic, not pre-diabetic, must make an effort if he is a candidate for SGLT2 inhibitors. We have different molecules now and quite economic also. We can give. In fact, it has been my practice for last maybe 1 or 1.5 year. I have introduced this drug in patients in regular management of patients with diabetes and the ASCVD. So there are many dedicated heart failure trials with now heart failure with reduced ejection fraction, and now we are getting trials on heart failure with preserved ejection fraction results. So I don't think there should be any confusion. Who are the patients who are candidates for this type of drugs? I think.
Yes, Dr. Sanjay, please continue.
So, that one thing which I always get confused is when you go to diabetologists' prescriptions and the recommendations, they say diabetologists with heart disease or heart failure or risk factors, yes, SGLT2 inhibitors are class 1. But how do we actually go for people who are just having diabetes and no other risk factors? For us, diabetes itself is a cardiovascular risk. It is a cardiovascular disease. It's not a risk factor anymore. So any person who has a long-standing diabetes is a cardiovascular disease in the making. So should we not actually change these guidelines? The diabetes guidelines actually dispel that, and they say those are simple diabetics. Please treat them with
sulfonylureas and metformin.
Not sulfonylureas, the DPP4 inhibitors or GLP-1 analogs. And SGLT2 inhibitors specifically for heart failure risks or risk factors for cardiovascular disease. So that is one of the things I would never understand.
I think it has been an exciting discovery, and I think all of us are very excited with this first time having a therapy for heart failure with preserved ejection fraction. And this has not only increased the interest in the treatment of heart failure with preserved ejection fraction, but among the physicians and among the diabetologists, the entity has become very much recognized now. We were trying to educate our physicians and diabetologists about this entity and our intensive care teams. We were always struggling that, there is this heart failure with preserved ejection fraction. Just looking at the echo ejection fraction and saying that it is not heart failure is just not the right way to approach. I think now the world has woken up to that diagnostic possibility, and a therapy is available. Because previously, even if you diagnose, then they would ask us like, what is the therapy you want to give them? And we didn't have any answers on the therapy side. So now I think increased recognition and early treatment will definitely make a huge impact. Thank you. Thank you, Sanjay sir.
Thank you.
Thank you, sir. You can disconnect Raghu, so we can disconnect the live webcast.
Yeah, it's that stopped. Kishore, stopped, right?
Recording stopped.
Yeah.
Okay.
Yeah.
Thanks, Raghu.
Kishore? Yeah.
Chalega,
Yes,
thanks.
sir, done.
Okay, right. All right. Thank you very much, Pradeep, for the opportunity. I really appreciate it because it's a work in these times. So I hope the program was as per your expectations.
Yeah. Thank you so much. I think we are still live. I'm not sure. But anyway, thank you so much.
No, we are not live on the webinar. We are only live here, and then in here there are no other doctors apart from us.
Okay. Bye-bye.
Right. Thank you. Have a nice evening. Bye-bye.